Good afternoon, everybody. I am Dr. Santosh Palkar, and I will be speaking on the management of BPH. Next. So, this is what Benjamin Brody has said. Basically, what it means is that the prostatic hyperplasia or enlargement of the prostate gland is a sign of aging. It occurs simultaneously with cataracts. You get the white hair coming in. So, all that with atherosclerosis. So, all these are symptoms or signs of aging. And it's a process of aging or a disease of aging that we are looking at. Next. Anatomically, this is how the prostate looks. It's a walnut shaped gland sitting right below the bladder, encompassing the your first tip, urethra, the male urethra. Next. This is a lateral view of the same thing, the prostate with the urethra in between. Next. Now, what we are talking about is benign prostatic hyperplasia. It's the most common tumor in men and is responsible for majority of urinary symptoms that occur in men older than 50 years of age. Next. Now, what is the pathophysiology of the obstruction that the prostate causes? There are two components to it. One is a mechanical component and the other is a dynamic component. In the mechanical component, there is an increase in the size of the gland. Now, various theories are postulated. One of them is there is a decreased rate of cell growth, there is an increase in androgen receptors, or there is a decrease in testosterone estrogen ratio, which causes an increase in the size of the gland, which causes mechanical obstruction. Next. The other component is a dynamic obstruction. The prostatic capsule is constructed of smooth muscle cells and collagen, which are very rich in alpha 1 adrenergic nerves. So the spasm or the contraction of the capsule also causes an obstruction in the prostate. Next. How will a patient with BPH present to us clinically? So these are the different signs and symptoms that the patient will come with. Firstly, they may have poor flow, hesitancy, which means a difficulty in initiating the flow of urine, post-void dribble. There may be a sense of incomplete evacuation. There could be frequency, more so night frequency, where the patient has to get up more than 3 times in the night and gets disturbed by it. Urgency and urge incontinence. Urgency is the desire to immediately evacuate the bladder. And if you are not able to find a bathroom, then there is a leakage of urine, which is the urge incontinence. Dysuria, which means burning or pain while passing urine. Hematuria, which is blood in the urine. And ultimately, some of the patients may present to you with retention of urine, and that is an inability to pass urine. Next. How do you go about evaluating a patient who comes to you with these signs and symptoms? You look at the symptom score. Then there is the physical examination, where the digital rectal examination is the key. You can get a basic blood and urine investigations done. We get a test known as serum PSA done. Ultrasonography will give us a picture of what is happening. If need be, you might have to do urodynamic evaluation and a cystourethoscopy in these patients to fully evaluate them. Next. When we talk about the symptom score, we talk about 7 symptoms where the patient scores from 0 to 5. So we first ask whether there is incomplete emptying. And if there is incomplete emptying, whether it's happening once or twice a day or more, accordingly to the severity of that incomplete emptying, the patient scores himself. Then the next question would be frequency, then intermittency, which means the urine flow stops and starts. The fourth symptom that we are talking about would be urgency. Next, please. Then there is a weak stream, straining to pass urine, and nocturia. That is the number of times that a patient gets up in the middle in the night to pass urine. So basically, from 0 to 5, 7 symptoms. So you have a scoring from 0 to 35. Depending on the symptom score, we grade them into mild symptoms, moderate symptoms, and severe symptoms. So basically, from 0 to 10, we would be mild symptoms. From 10 to 25 would be moderate symptoms. From 25 to 35, we would be looking at severe symptoms. Next, please. The next score that we would look at is the quality of life score, whether the patient is happy with the symptoms that he has. Again, he scores himself from 0 to 6. Now, these scores will help us decide the form of treatment that we would be offering the patient. Next, please. The main thing, other than a basic general examination where we monitor the pulse, the blood pressure, abdomen, see for other signs, would be the digital rectal examination. Now, in the digital rectal examination, we would look at the size of the prostate, the consistency, whether it's firm or hard, whether it is mobile or it is fixed to the adjacent tissues, and the limits, how big from where to where it extends. This basically is done to differentiate between a benign prostatic hyperplasia, cancer of the prostate, and whether there is some infection, abscess, or prostatitis. We can really, with experience, come to know in a digital rectal examination. Next, please. In the blood test, I spoke about prostate-specific antigen. Now, this prostate-specific antigen is a glycoprotein which is produced exclusively by the prostatic epithelium. It will increase in most cases of TA prostate, and it will slowly rise with age and the volume of the prostate. But this is mostly used as a marker for cancer of the prostate. So, in most patients who come with BPH, because a cancer of the prostate may coexist with a BPH and symptoms of BPH, we would do in most all the patients who come present to us with a benign prostatic hyperplasia. Next, please. These are the values that we would be looking at. 0.5 to 4 are normal values, 4 to 10 are borderline values, and more than 10, there is a high risk of cancer of the prostate. If we get values in the borderline range, we would do a total and a free to total ratio. A free to total ratio, which is more than 0.11, is more towards a benign etiology. Less than 0.11, we look at cancers of the prostate. Next, please. Another key investigation that we would be doing is an ultrasonography. What are we looking for in ultrasonography? We are looking for the upper tracts, associated problems, whether there are stones, there is hydronephrosis, there is fullness, there are any congenital anomalies in the kidneys. Then we would look at the size of the gland as measured by the ultrasound. And we would also be looking at residual urine. So the patient is seen on a full bladder, asked to empty himself and come, and the amount of residue that he keeps is measured. So we get an idea as to how much of residual urine there is. So percentage of residual urine as per the full bladder will also be known to us. Next, please. The other way of doing an ultrasound for the prostate would be a transrectal ultrasound. Transrectal ultrasound will better anatomically delineate the gland. We could be able to pick out small lesions or small nodules in the gland by a transrectal ultrasound. There could be also an easy way of studying capsular penetration. Transrectal ultrasound is also useful if we are suspecting cancers of the prostate to take a biopsy of the prostate. So you can take multiple core biopsies using the transrectal ultrasound and guiding the needle under ultrasound control. Next, please. Urodynamics. Urodynamics may not be required in all patients of benign prostatic hyperplasia. In some patients, we would need to look at urodynamics. Uroflow, we might do in all patients, it just measures the flow of urine in ml per second. Cystometry gives you the bladder pressures that are developed. Sometimes patients have hypotonic or atonic bladders, which means that the bladders themselves are not capable of pushing urine out. Such cases, even if they have a obstructive component, they would not do well with surgery until the bladder pressure or the bladder tone improves. So cystometry would give us an idea of the tone of the bladder, and which is why we might do cystometry in some patients whom we suspect hypotonic or overtonic bladders. Next, please. This is how a uroflowmetry chart would look like. This is a poor flow with intermittency. Patient stops, starts. The maximum flow is less than 6 ml per second. Normal person would have a maximum flow of more than 20 ml per second. Even the average flow is very poor. So this is a poor flow that we have recorded on uroflowmetry. Next, please. Now that you have diagnosed a BPH, how do you go about managing it? We have major two forms of management. One is the medical management, which we would look at first, specifically in patients who have moderate to mild symptoms. The first thing that we would, there are two main group of drugs that are being used. One is alpha adrenergic receptor antagonists and 5-alpha reductase inhibitors. Next, please. So when we come to alpha adrenergic receptor antagonists, we have about 3 or 4 of them that we regularly been using. First one is terazosin, which is rarely used nowadays. It is a non-selective receptor antagonist. Hypotension is a common side effect. It does not improve irritative symptoms, and the dosage is once daily, 1 to 5 milligram. Next, please. Tamsulosin. This is the most commonly used drug that we use. This is it's one alpha 1A adrenoreceptor blocker. You don't need to titrate the dose. 0.04 is the dose that we use as a single dose. Does tend to improve irritative symptoms, has very minimal effects on blood pressure. The main problem with alpha adrenergic receptor blockers is that they cause retrograde ejaculation. So this is something that may need to be explained to the patients when you start this drug, that they will get a dry ejaculate. Because the ejaculation occurs, but it tends to go back retrograde into the bladder. Next, please. Alfuzosin. It is basically a short-acting drug, which is now available in an extended release formulation. It supposed to give a better relief of obstructive symptoms. Is probably the lowest as far as retrograde ejaculation is concerned. Has the least chance of getting retrograde ejaculation. 10 milligram is the daily dose. So this is the drug that we would use in the younger group of patients who are symptomatic with BPH. So somebody with around 50 who is symptomatic of BPH, I would prefer to use alfuzosin instead of tamsulosin. Next, please. Silodosin. This is a newer selective alpha receptor blocker. It has a better safety profile than all the other alpha receptor blockers, likely to cause ejaculatory problems. Dose is 8 milligrams. It's also available in 4 milligrams. So if you find that a patient is not tolerating 8, you could always start off with 4 and then increase to 8 again. But normally we would start with a dose of 8 milligrams. Next, please. Naftopidil had come in between, would not be easily available. It has an affinity for alpha 1D receptors, which are very well spread out in the bladder. So storage and irritative symptoms are supposed to have been better taken care of by naftopidil. The dosage is 25 to 75 milligram per day. Basically, all of them are single dose. Next, please. The next group of drugs is the one that we know as 5-alpha reductase inhibitors. Basically, 5-alpha reductase is the enzyme that converts testosterone to dihydrotestosterone, which is the active androgen that is there in the body. Now, next, please. There are two drugs that are available in this category. One is finasteride, which is a 4-azosteroid. It is an inhibitor of 5-alpha reductase, so it prevents testosterone to be converted into the dihydrotestosterone, and that's how it works. Its dose is about 5 milligram per day, single dose. All these 5-alpha reductase inhibitors should reduce PSA by 50% in 6 months. I'm saying this for the simple reason that after 6 months of 5-alpha reductase, if you find that the PSA has not come down, it's a red flag. We may be looking at cancer of the prostate, so you have to be careful, check out the patient and see what it is, because otherwise, once they're on a 5-alpha reductase inhibitor, the PSA should come down. And no significant side effects with this drug. Next, please. Dutasteride. This is the second 4-azosteroid drug, which is a 5-alpha reductase inhibitors. It has a faster and an increased action, used as a dose of 0.5 milligram. Onset of action is far more rapid than finasteride, but after about a month or so, probably the effect of both of these drugs is more or less the same. Next, please. So which would you use, an alpha blocker or a 5-alpha reductase inhibitor? Now, there are a lot of studies and a lot of multiple trials which say that because they work at different levels or at different positions, they can be used synergistically and we can combine the two and use. Small prostates, probably just an alpha blocker would suffice because it will take care of the capsular or the dynamic component. If it's a slightly larger prostate, then we would probably be better off using a combination of an alpha blocker with a 5-alpha reductase inhibitor so that you take care of the dynamic as well as the mechanical component of the obstruction with these two drugs. Next, please. Muscarinic receptor antagonists. Now, that you can use anti-muscarinic therapy in patients who have severe symptoms, mainly irritative symptoms, that is frequency, urgency, difficult to urge incontinence. These are patients who would benefit with an addition of muscarinic receptor antagonists. Next, please. So beta 3 receptor agonist is mirabegron, and this has been combined in doses ranging from 25 to 50 milligram along with an alpha blocker. And we use this in patients who have mainly an irritative component That is, they have more of urgency, frequency, urge incontinence, nocturia, and less of an obstructive component where the flow is pretty okay, not much of a residual urine. So this can be helpful in treating the irritative component of BPH. Next, please. The other group of drugs that has been used is phosphodiesterase inhibitors, PDE5 inhibitors can be used in patients with or without erectile dysfunction. PDE5 erectile inhibitors, as you know, are used for erectile dysfunction. An addition of tadalafil 5 milligram per day on a daily basis along with an alpha blocker can help patients because it will act on the BPH component and may also help in the erectile dysfunction that a lot of these patients have at this age. Next, please. Psychotherapy. Now, this is I have put in just because there are a lot of drugs that are being used outside and in our country over the counter, like saw palmetto. We have Bangshil available, Prostina available, Prostige available, and a lot of patients keep taking this. We don't know whether they work or they don't know work. There is no clear data about how they work and what they work. So this is just for me. I am just mentioning this, nothing more than that. Next, please. MIST. MIST stands for minimal invasive therapy for BPH. So there is a whole list of minimal invasive therapies that can be placed between medical management and the surgical management and which are there. But these are not the standard treatments. These are basically treatments that may benefit or may be offered to patients with specific issues or specific problems of fitness and all that. So what we have is balloon dilatation, then we'll have prosthetic stents, then you have a procedure called as Eurolift, then you have a procedure called as TUNA, which is transurethral needle ablation, then microwave therapy, then you have a high frequency focused ultrasound, then you have some kind of laser which causes just coagulation of the prostate, and aqua ablation or RESM that is there. What is not there, one more therapy which is not there is PEA or PAE or prostatic artery embolization, which is also being done in some centers around the world. So these are the various forms of minimal invasive therapies for BPH that are being used, that have been tried. Some centers may be doing them. But as I told you, these are more tuned for specific investigations and specific patients than in general. Next, please. So this is how a balloon dilatation would be done. Next, please. This is a prosthetic stent that has been put in. Next, please. This is how a Eurolift procedure is being done so that the prostate gets lifted away from the urethra and the urethra opens out. Next, please. This is TUNA, where you have two needles which go into the prostate and you cause ablation of areas in the prostate so that the prostate shrinks and the passage opens out. Next. This is microwave therapy, where you are using microwaves to cause lesions in the prostate. Next, please. This is HIFU, where the focused ultrasound. So wherever the ultrasound gets focused, heat is generated and you get a lesion formed, or small lesions can be ablated using this. And once the lesions form and the prostate opens out, then over a period of time, the patient's urine flow will improve. Next, please. Radium also is a similar thing where you have aqua ablation, where you use water vapor to cause ablation of the prostate. And over a period of 2 to 3 weeks, then the prostate shrinks and the passage opens out and your flow improves. The next group of management would be surgical management of BPH, in which I would use TUIP, which is the standard treatment, a bipolar TUIP, which most people are doing nowadays, very similar to the TUIP that we are doing. And then lasers, which also are being used in quite a few centers in this country and abroad. Next, please. Transurethral resection, as I said, is a reference standard. We use an electrocautery with irrigation. Tissue is available for histopathology. Next, please. So this is how a standard TURP would look like. This is the prostate that is shown on the left side. After we have removed out using something where you chip out the prostate, you get a fossa which is open like this, and you get a free flow of urine. Next, please. What are the complication concerns that we are really looking at? Major thing we are looking at is hemorrhage, which could be primary, secondary, after 5-6 days also. But TUR syndrome, this is something that would happen intraoperative when water gets, large quantities of water, which is used as an irrigant, gets absorbed. Incontinence and strictures are not very common. Incontinence is rarely seen in a patient with a standard TURP. There is a 10% risk of strictures post the procedure, but that can be managed. Next, please. There are no clear studies that would link TURP with in post-operative importance. So may occur simultaneously as a part of the aging process. All patients who have had a TURP will definitely get retrograde ejaculation. So this is something that needs to be explained again to the patient who is going to undergo TURP, that there will be retrograde ejaculation. Next, please. Chances of repeat TURP. There are 3 reasons why there could be re-TURP. First instance, if for some reason it has not been done to completion, whether there was a very large gland or there was a lot of bleeding or something, you may have residual tissue which might require re-TURP. Small glands, specifically, you can get bladder neck stenosis post-surgery. So that may require an incision post as a procedure. Regrowth of tissue is not very common. In 10% people, after 10 to 15 years, you may get regrowth of prostatic tissue, and they might require to undergo a re-TURP. Next, please. This is something very important that we should remember, that once a TURP done, TURP removes the enlarged gland from inside, leaving the capsule intact. So compressed prostatic tissue, which is remaining in the capsule, is still likely to develop a cancer of the prostate. So just doing a TURP does not take away the risk of cancers of the prostate from the patient. Next, please. Bipolar TURP. This is what we are normally doing on a regular basis now. We use a bipolar cautery. We can use saline as an irrigation fluid, so water is not used. So chances of a TURP syndrome and hyponatremia and hemolysis are very low. Coagulation is much better with a bipolar TURP, so bleeding is much less. And the instrumentation is very similar to TURP, so there is no major learning curve. Next, please. Lasers. Now, laser is an acronym for light amplification by stimulated emission of radiation. Next, please. So this is how the lasers are. There is a lasing media and mirror used to amplify and get a nice collimated beam of light. Next. So you get an excellent beam quality. There is low divergence. The wavelength is defined by the lasing media, and we can have continuous wave lasers or pulse lasers which can be used. Next, please. This is how the wavelengths are. Next, please. NDR, KTP, holmium, thulium, diode, pulse dye. These are the lasers that basically have been used in urology. Now, specifically, the main two lasers that are being used are the holmium and the thulium lasers. Next, please. So, how can the lasers be used? The lasers can be used for coagulation. So, you can have surface coagulation or interstitial coagulation, which is a missed kind of surgery where you cause lesions in the prostate. The lesions will cause shrinkage of the prostate and the passage opens out. You could actually use the laser for vaporization, like the KTP laser, which is used for vaporization of the prostate. So the prostate vaporizes in front of you and you get an open fossa. The main use is use of holmium or thulium to enucleate the prostate. So enucleate the prostate, we make cuts on either side of the median lobe. You enucleate the lateral lobe, the median lobe, and the two lateral lobes separately. Push them into the bladder. Use a oscillator to take out that, and you get a good, nice open fossa. Next, please. That is what HOLEP is about. Normal saline is used as an irrigant. Bleeding is much less. The hospital stay required for a HOLEP is much shorter than what they would require for a TURP. Only thing is, most of the time, it would end up being slightly costlier than a standard TURP. Next, please. Thank you. Anybody has any questions, I would be willing to take them.
Any participants having any questions can please unmute themselves and put
Hello.
their question.
Hello.
Yes.
I'm Dr. Kirti Gangar. I
Uh,
joined little late, but you are speaking about something about Mirabeg. The use of Mirabeg in benign prostatic hypertrophy.
See,
Can you just
basically, mirabegron would be used in patients who have got mainly irritative symptoms. That is urgency, frequency, nocturia, urge incontinence,
okay?
along with BPH. You will, when you see BPH patients, you tend to see two group of patients. One is patients with predominantly obstructive symptoms and some with predominantly irritative symptoms.
Okay.
Now, if you have a BPH patient with irritative symptoms, then you could add mirabegron along with an alpha blocker, and that sometimes helps the patient better than just using an alpha blocker.
But dutastride can be used along with it.
Dutasteride also can be used along with it. So you can give a combination of alpha blocker with dutasteride and then give mirabegron as a separate entity.
Okay. 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 Thank you, sir. Thank you.
Okay.
Anybody else having any question? If there are no questions, then we can close this session. So I, Francis Gaikwad, Marketing Manager, Rani Hospital, take this opportunity to thank Dr. Palkar for taking us through this wonderful session on BPH. So, Doctor Sir, Thank you very much on behalf of Rani Hospital for this session. So we can end the session over here.
Okay, thank you.
Thank you so much, everybody, for participating and giving your valuable time to us. Thanks a lot.
Okay.